Hi, welcome to On Becoming a Healer. I'm Stefan Kertész. In the last 25 years, there's been a movement in medicine called narrative medicine, and it's emerged in medical schools across the country in the name of making us better doctors. Narrative medicine asks us healthcare workers to read and interpret stories, to listen in a deep and serious way, and to write our own stories. It has a formal definition from Dr. Rita Sharon of Columbia University. She talks about it as, quote, medicine practiced with the narrative competence to recognize, absorb, interpret, and be moved by the stories of illness. And when I read this, I recall we had a wonderful podcast about a story written by James Baldwin just a few months ago about two brothers suffering in their own way. Today we have both my co-host and a special guest. My co-host Saul Weiner is a little skeptical of the enterprise of narrative medicine defined in the way I just said. Hi, Saul.
Hi, Stefan.
So I do hear you're going to have some concerns about this?
Yeah, it's something I've been wanting to talk about for a while, so I'm glad we're going to get to do that.
I'm eager to hear you out, but before we do that, I want to mention we have a return guest, Professor Laura Greene from Augustana College. Hi, Laura.
Hi, Stefan.
It's super great to have you back, and I only offered a kind of thumbnail, skinny introduction of what this concept of narrative medicine is, and I kind of hope you would help us embark on this. What are we talking about here?
Sure. Narrative medicine came out of a broader movement of sort of medicine and the humanities. And that arose, I think, largely because there was a sense that patients had that doctors were treating their bodies, but they were not acknowledging or trying to treat their suffering, and indeed sometimes contributed to patient suffering. And also a sense of a kind of power imbalance between doctor and patient, particularly as it pertains to story and narrative. The idea that medical chart became the authoritative story of the illness, but left out a patient's experience and, in effect, robbed them of their voice. So narrative medicine was sort of born out of those two concerns. You know, it's a big umbrella that includes lots of different activities, including reading and interpreting and responding to poems, having healthcare workers do that, eliciting and listening to and interpreting patient stories, having physicians write their own stories, and having physicians write about their patients in something called a parallel chart, which we can talk about a little bit later.
Oh, we will.
Yes, we will. As you, Rita Sharon is the one who coined the term narrative medicine, and she defines it as you said, which is medicine practiced with narrative competence to recognize, absorb, interpret, and be moved by the stories of illness. Her claim is that narrative is tied up intricately with human endeavors and fundamental human needs, such as recognizing self and other, connecting with traditions, finding meaning in events, and celebrating relationships. I was quoting her there. And
I like that.
She's saying that her claim is that narrative competence will help physicians, this is a quote again, more ably recognize patients and diseases, convey knowledge and regard, join humbly with colleagues, and accompany patients and their families through the ordeals of illness. These capacities will lead to more humane, more ethical, and perhaps more effective care, is what she says. Now, that's a pretty broad and abstract definition, so I'm going to try to make it a little bit more...
Give us some specifics. Lay some meat on this.
Yeah, I'll try to do that. And I think maybe the first thing I want to do is, because I know that Saul is skeptical of narrative medicine, I'm going to sort of try to key these definitions and explanations to his ideas from On Becoming a Healer, because I think there's actually a lot of overlap between what Saul wants to accomplish.
I can hear it too.
Right, yes. So, okay. So I got essentially 6 aims and potential benefits of narrative medicine. Okay. One is to read poems and stories to foster engagement. That's what Saul's all about, right? And compassion for the patient helps the physician to better view the patient's experience and point of view and more vividly understand the many ways that patients can suffer. This seems to me like it helps combat the problem of physicians who are just efficient task completers. Since narrative medicine encourages physicians to see patients in their full humanity, Franz Kafka once famously wrote, "A book must be the axe for the frozen sea within us." As though as though we are all sort of frozen inside, and what literature can do is sort of take an axe to that frost and bring us back to our humanity and our feelings. And I mean, poems and stories indeed do try to get you to feel, to live through an experience, and not just sum it up in abstract terms. Poets in particular are trying to get you to to get to you through your senses, what you see, what you hear, and involve you emotionally in the life of a particular person and what they're feeling and thinking. And literature has a kind of advantage in that it can take you directly into somebody's mind in a way that we never can get to in real life. So the first thing is sort of break through that kind of mechanical, efficient task completer mindset and remember that you're dealing with human beings here and sort of reawaken your own sensitivity to your feelings and the feelings that your patient might have. Okay, number 2 is imagining things from another person's point of view, which is what Sharon regularly advises, can help doctors move past judgmentalism to engage with patients, especially patients that are different from you. Again, that's one of Saul's major points. Like I said, stories can give you sort of direct access to a person's mind in all its nuances, which helps you connect and empathize with people who are very different from you. And further, eliciting stories from patients, particularly patients in stigmatized groups, can help doctors see and experience them as full and complex human beings. Daniel Ofri tells a story of dealing with somebody with an opioid use disorder, I believe, and none of the residents were paying attention to the guy. They experienced him as sort of irritating. And she just asked him a question like, well, can you tell us when you first knew that you were addicted? And he tells this really amazing, interesting story, which suddenly engaged all the residents who are otherwise irritated and bored to be there. And they started to engage with this guy and not judge him. And that it's not like he walked out of there no longer addicted and perfect, but there was a connection made where at least some sort of intervention might happen then, was possible.
I've seen that happen.
Do you?
Yeah. I've had the exact same thing where I asked the patient, oh, you're here for treatment for addiction. Why do you want to do this? And it enlivened the residents.
Yeah.
He said, I want to get back to work. I'm a tailor. And that, I could tell it captured the residents' attention.
Yeah, just the specificity of it.
Yeah.
And the sense that, oh, this is a person with more to them than just the fact that they use heroin or whatever. Okay, 3 is applying literary techniques of what English teachers call close reading, which sort of is translated into close listening if you're a doctor, I think. But it is sort of listening very carefully to what patients say, not only what they say, but how they say it, in order to better understand the patient and their context and identify contextual red flags. Now, that part I added in again because it connects with Saul, but I think that is the point of a big part of the point of close reading or close listening is to get the full story on the patient, which would include context and contextual red flags. And this could or would hopefully make a doctor a better diagnostician. That is certainly Sharon's claim, and help them come up with more effective treatment plans that take a patient's life context into consideration. When you interpret literature, you pay attention to details, to word choice, metaphors, tone, textual inconsistencies, gaps, silences, what doesn't get said sometimes is as important as what does. You look at all these for what they might reveal about a character and their situation. I think the idea is that these skills might then improve how carefully you listen to your patient and the way they tell their story. Important parts of their situation that their language might only briefly allude to or imply, but then the doctor can probe further for contextual red flags.
Yeah, that seems totally resonant with prior episodes on this podcast,
yes.
By the way.
Yes, indeed. Well, I'm sort of going to allude to that, I think, in the next one, which is that reading and writing and sharing stories doesn't only help patients, but can help healthcare workers address unprocessed trauma and give them a forum to express grief and therefore reduce burnout, at least one would hope. Because stories are structures, and I guess I want to emphasize that quite a bit, that stories are not just sort of general assemblages of words, that they are selective. Stories deliberately focus our attention on some things and exclude others. Who cares if the main character brushed their teeth in that morning, right? Instead of just a meaningless jumble of incidents, they have plots, which imply causality. They use deliberate patterns, for example, repeating images that can move beyond the literal and confer significance. And they impose beginnings and endings, which bring shape and meaning to the experience being described. It's like putting boundaries around the messiness of life so we can make sense of it and construct meaning from the chaos. That matters enormously, I think, because the meanings a person ascribes to their illness can make a huge difference in how they cope with it. Behind all literature, I think, is the assumption that careful use of words is what helps us construct meaning. And so to ask a doctor to write about or a health coworker to write about one of their own situations that was traumatic helps bring order to a disordered experience. And I think that's what we did when we were talking about Sonny's Blues, or what we were urging other healthcare workers to do.
Just 4 months ago.
Yeah, 4 months ago, exactly. That we were trying to look at the main character, the narrator, as a sort of stand-in for a doctor who had, in effect, chewed off one of his own limbs to try to survive in the situation that he was in, but who was trying to get better, who was trying to tell a different story or understand the world differently. And I think, that story could be, we hope at least, very helpful to physicians in that position.
So that's the fourth potential meaning of narrative medicine, helping us as clinicians.
Exactly. The fifth is having doctors write about patients in something called a parallel chart, which I'll explain in a bit, but so that physicians might better identify, reflect on, and address problems with boundary clarity. Now, Sharon doesn't put it in terms of boundary clarity. I'm the one making that connection, but I think it works pretty well. And this is something Saul cares an awful lot about. Saul, could you perhaps quickly define boundary clarity for us?
Yeah, boundary clarity is, I think of it as the ability to know what is you versus what is me. So when you're with a patient, if you're feeling enraged at them for some reason, because they're not showing appreciation, or they're frustrated and you've been doing everything you can and they don't seem to be doing their part, that you're able to recognize that the emotions you're feeling are not the ones to act on. Because if you do that, you're going to fail to instead try to figure out why they're behaving the way they are, which is what a doctor should do. That's what's going to be therapeutic. And so the capacity to do that, to say, this isn't about reacting to my emotions, this is about setting those aside, understanding that they make perfect sense, setting them aside and focusing on what's going on with this other person, that's boundary clarity.
Yeah. And what Sharon proposes when she talks about parallel charts is that it's a chart that doctors or residents keep on a patient that is separate from their medical chart, and in part gives them place to deal with their sort of personal reactions to this patient. So she writes, for example, if your patient dying of prostate cancer reminds you of your grandfather who died of that disease last summer, and each time you go into the patient's room, you weep for the grandfather, you cannot write that in the hospital chart. We will not let you. And yet it has to be written somewhere. You write it in the parallel chart, she says. So, and Danielle Ofri also tells a pretty interesting story about, getting pretty pissed off at a patient who was demanding a weight loss drug, and Ofri was sort of reacting, bristling against that challenge to her authority, and how that emotion got in her way and kept her from asking important questions about domestic abuse or eating disorders. So here, reading and writing as a way to try to remember what is self and what is not self, so that you can attend to the patient's needs without letting your own needs and desires impose on the patient.
So important. So important.
Yeah. Yeah.
Now we're up to 6, I think.
Yeah, this is the last one. This is less about Rita Sharon, I should say. This is more draws on the work of a guy named Arthur Frank, who's a sociologist who's also had some very serious illnesses. But he's interested in identifying common stories that our culture tells about illness, and how that can help make doctors aware of how such stories might help or hinder suffering people, both patients and healthcare workers. And it can also help doctors identify some of their own assumptions and biases about patients. I talked earlier about the structure of stories help bringing order and meaning to chaotic experiences. And that's a very powerful function of story, but story can also be distorting and constraining. Reminds me a little bit about Stefan's point in a podcast, I think 2 months ago, about the medical model of addiction, how it sort of clarifies certain things, but also puts on certain constraints. So people who, the problem here is like people whose experiences don't fit the preferred or cultural plots of a particular illness, for example, are often marginalized and their reality is ignored or denied. That would be, I think, especially true of people who suffer from chronic relapsing or terminal illnesses. And also people with certain illnesses are often, I think, treated like stock characters, like their motives are already defined, their plots are already determined. So a young woman with unremarkable test results and strange symptoms are mentally
Oh,
ill.
hysteric. That's
Yes,
the word, right?
exactly.
It's a freighted word because it
Yep,
embodies the
exactly.
uterus.
The wandering womb, that's where hysteria comes from. And people with drug use disorders, we assume are weak-willed and will inevitably relapse, etc. So there's the sense that narratives can have this controlling power, and you ought to be aware of it so that you don't get caught in and trapped by certain narratives. And that's all I got.
So what you've done here is lay out 6 potential meanings and uses for narrative medicine. Not every single one of them is in Rita Sharon's book or in her writings, but they're all very powerful. And I heard, just to highlight, the value of listening in a particular way to help understand what people are saying and see where the gaps are, the importance of using stories in part, sharing them so that we can process our own internal emotions, the value of the parallel chart, taking notes so that we can separate in terms of boundaries between ourselves and the other. And so much of what you said actually rings a bell with this podcast and with the work of Saul Weiner in his own book on becoming a healer.
Yeah.
And so I'm now incredibly puzzled as to why my friend, my co-host, Dr. Weiner, is entertaining a kind of skepticism or reaction against something that seems to be entirely aligned with the purpose and the mission of our podcast. What is going on, Saul?
All right, Stefan and Laura, thank you for making the case for narrative medicine, which I think Laura did beautifully. So I have to start by saying that English was my favorite class, starting in junior high school. I just loved English class, and it's that never changed. I've always loved reading literature, reflecting on it, discussing it. And yet I decided to become a physician rather than an English professor. But I often thought that I actually have a learning disability, and I wasn't sure I was going to make it through medical school. And I thought that if I didn't make it into medical school, I would probably end up becoming an English teacher. So, which, by the way, would have been fantastic. It wouldn't have been a problem. But I think that one of the differences between reading literature or reflecting on what's in a story and looking at a character and interacting with a real human being, with a patient, is that the former is a one-way process where you're essentially imagining into the story, and that's what makes reading fun. And the other is an interaction between two individuals, which is full of complexity and nuance and is often fraught. And I think it's incredibly important to be specific about this difference. I don't hear enough discussion in the work on narrative medicine and among those who use literature and the humanities to teach physicians about this limitation. And if you don't talk about this limitation, you tend to fall into certain traps. And one of those traps is you start thinking about the doctor-patient relationship in a way that mimics, unfortunately, the reading into literature, produces a set of assumptions that you know what the patient is experiencing. And if you think you know what the patient is experiencing, you may be less likely to ask them. So Dr. Sharon, for instance, writes, and I'm looking now at her book, Narrative Medicine, Honoring the Stories of Illness. She writes, and this is on page 9, to know what patients endure at the hands of illness, and therefore to be of clinical help, requires that doctors enter the world of their patients, if only imaginatively, and to see and interpret these words from the patient's point of view. I think this is fundamentally wrong. I think that you just can't really know what your patients are enduring at the hands of illness, and you can't really enter their world. I mean, you can do that if it's a novel, right? You can do that if it's a character in a story. But if it's a person in front of you, it's a whole nother ballgame. And in fact, if you think you know what they're experiencing, or if you think that what you're imagining they're experiencing bears any resemblance to it, you might not ask them, and you might make assumptions. And I'd love to quote here Eric Cassell in his 2004 book, The Nature of Suffering and the Goals of Medicine. He writes, quote, "The only way to learn what damage is sufficient to cause suffering or whatever suffering is present is to ask the sufferer." Now, this is not just an academic thing. One of the things that I want to point out as we go through this discussion is that if you look at specific examples that Dr. Sharon highlights often, for example, in a seminal JAMA piece she wrote on this in her book, that this is a repeated thing, that there will be this discussion of a case, and then she'll talk about all the feelings that she or the medical student or whoever it is had, and how deeply they felt about the suffering of the patient and how deeply they felt connected, but she doesn't tell us anything about whether they asked the patient any questions. Did they find out what the patient is going through, what they could do to help them? That rarely happens. And so we're left just with this weird sense that this was a story, not an interaction between two individuals. And so I'd like to actually take some of the examples from Sharon's most prominent writings to kind of illustrate what we're talking about. But I'll just pause for a moment and see if what I'm saying makes any sense.
It is absolutely true that you can do things in literature that you cannot do in real life. If you've got an omniscient narrator, you get clear access into a character's mind, and you'll never get that in real life. So I certainly agree with the point that there are limits to what literature can help us understand. And it's a different ballgame when you're dealing with an actual person. I would say a lot of these skills are analogous. So you try to learn to pay careful attention to a literary character, and that maybe will help you pay more close attention to a real person in front of you. But when push comes to shove, there's a real person in front of you. And if they irritate you, you've got to deal with it. You can't just close the book and walk away.
Yeah, and I think that if you recognize this limitation, that's fine. But what I'm going to try to demonstrate is that there's been a failure to recognize it. And the failure to recognize it leads to this chronic problem that I see where assumptions are made about patients, and that replaces getting to know them, asking them questions, developing a connection, and ultimately working to help them in a very pragmatic way based on what they have to tell you. And so if we take, for instance, I'm thinking now of a piece in JAMA that Dr. Sharon wrote called Narrative Medicine, a Model for Empathy, Reflection, Profession, and Trust. And there's a case of a Ms. Lambert. I think you're looking at it, Stefan. Do you want to relate that case?
So this piece in JAMA from 2001 begins with the description of a patient whose identity was changed, a 33-year-old woman with a degenerative neurological type of condition called Charcot-Marie Tooth disease, and it is heritable. Her grandmother, other members of the family have it. It's terrible to have it. 2 nieces already have shown signs of it by the age of 2, and the physician is described as asking how is her son, named Philip, of age 7. And this is a wonderful kid. And the patient says that now her son has weakness in both feet and legs. And the patient knows what this signifies, that there's likely to be the same disease that's plagued so many others. And it's been very difficult to see this happen at age 7. And Dr. Sharon writes, the physician too is engulfed by sadness as she listens to her patient, measuring the magnitude of her loss. She too had dared to hope for health for Philip. The physician grieves along with the patient, aware anew of how disease changes everything, what it means, what it claims, how random is its unfairness. And she goes on.
Yeah, I mean, at that point, she says, this is narrative competence, the competence that human beings use to absorb, interpret, and respond to stories.
You got something against connecting up?
When you hear bad news, when a patient shares bad news with you, the simple act of grieving with them is inherently valuable. It's very meaningful, in fact. So I don't want to diminish that. All I'm saying is that it's not enough. What strikes me is what's missing. So what we don't hear is any questions on her part. She doesn't ask the patient, at least this isn't shared with us, she doesn't ask the patient, so how has this been for you? What's going on? What kind of support do you have? What has this been like for you? What it's been like for your son? Is there anything I can do to help? It's all about how she is engulfed by sadness, the physician, and how she essentially just feels deeply for what's happening. And I pick out this case because I see this over and over again. This is the case she chose to feature in her JAMA paper and to call it narrative competence. Now, if this were a story about somebody in this situation and you're reading it, that's what's going to happen. As a reader, you're going to have that emotive response. You may feel sadness. You may feel a sense of shared grief, particularly if it's a memoir, for instance. But if it's a real patient, how do you then respond? What questions do you ask them? What additional information do you elicit? And this is where Eric Cassell's comment comes in. The assumptions you're making about what that person may be feeling, experiencing, or needing may be correct, may be incorrect. Unfortunately, if you think you know, maybe you're less likely to ask them. But what we see here is an absence of that. Which is something I see a lot of. And just this absence of question asking and replacing it with just a sort of reading into the emotive part of it, which I think falls short of what the doctor-patient relationship requires. My mentor, Simon Auster, I really said something which I think is beautiful, which he said, you show that you care by the questions that you ask. The way you show you care is by asking questions. It shows that you're trying to really figure out, oh, wow, so this bad thing has happened to this woman I care for. Her son has this bad illness. I need to figure out like exactly where is she in this process? Is she coping? Does she have help? Is there anything I can do to help her? That's caring. It's a very active process.
Okay, so feeling deeply about something isn't the same as asking about it. I think you're saying this crops up more than once in the narrative medicine book that we all took a look at by Dr. Sharon.
I'm not trying to single this. I'm picking the story because it's typical. In fact, I think we should pick some other examples. Laura, you talked about the parallel chart, and I if you want to just tell a little bit more about that, because I think that's an opportunity where you can either get it wrong or get it right, because a parallel chart does give you an opportunity to reflect on something for a patient you've been caring for, and then maybe go back and do things differently. Do you want to say a little bit more about the parallel chart, Laura?
Yeah, this is Sharon's particular innovation. And I think she does it with medical students that she works with. And she has them keep not only the regular chart on particular patients, but what she calls the parallel chart. And her directions are very broad, which is to say, whatever you are thinking or feeling about the patient that can't go in the regular chart. And then what they do is each brings in a entry from their parallel chart on one of their patients, and they read it aloud, and they discuss it together and analyze what they've written for its sort of literary qualities. Where does it start? Where does it end? What metaphors get used? Things like that. I mean, this is where she's actually, at least to my mind, kind of confusing. Like on the one hand, she seems to imply, I think, that this is a way to sort of help doctors get boundary clarity to deal with their own emotions so that it doesn't affect how they deal with a patient. But at other times, she's pretty heavily insistent that this is not about therapy for the doctor. It's not like a diary. It's not. So I'm a little puzzled, I suppose, about what the aims of it are exactly. But the aims that make sense to me, at least, I will say, are trying to sort out boundary clarity.
Stefan, would you like to read? Let's just take the first example from page 160. With David, who is the medical student, and she has 2 paragraphs from his parallel chart.
So here, I'm going to read what was said to have been read by David, and we are going to focus not just on that story, but specifically on the reactions of what narrative medicine seeks to achieve through these stories. So this is the patient story. It's written by a medical student. SC is a 79-year-old Black female with CHF, that's congestive heart failure, a host of medical problems, and a poor prognosis. There's not much for our team to offer her. We'll keep her symptoms under control and we'll assess how long she has to live, but we really won't accomplish amazing medical things in her life. But what we've done is to give her a sense that we're here, that we'll stand by her, and that alone has made all the difference in her world. She's afraid, but she's calm. She's worried, but appreciative and trusting. She is accepting the decline at the end of life with great dignity. She's the kind of person I want to be when I'm facing my own frailty and decay. I want to be like her when I'm dying. I want my heart to be as soft as hers when I'm through this life. I find myself frequently daydreaming about how this woman copes with the debilitation and despair. I want to learn from this woman. I want to listen to her. I want to understand her. I'm blessed to have the time I do have to be with her and to take care of her. And David is described as reading slowly and earnestly. He's described as moving from she to how he's feeling. And she relates a good deal of admiration for the stance of the author of this story, who begins to see in this Black female, we learn he's white and he's a medical student, a model for himself. So is this useful?
I mean, I think this is just another example of what troubles me. So it's kind of all about him. She writes, David has noticed the difference between the collective work of medicine and the individual work of medicine, the we and the I. And she goes on to say that his perspective is, quote, almost shocking in its intimacy. Here is a white man, Ivy League college graduate, sturdy in his evident good health, in his mid-20s, making a powerful interior connection with an old Black woman, ill, poor, not educated. First of all, it kind of made me cringe because the focus is really on how sensitive this white privileged guy is. And the patient is, quite frankly, a kind of a prop. Like we don't hear from her. She's apparently just dying. And, she evokes all this feeling at him. And he goes on to say that, this is something you read that stood out for me. But what we've done is to give her a sense that we're here and that we'll stand by her. And that alone has made all the difference in her world. Well, how does he know that? How does he know that his being there has made any difference in her world? We never hear him talk. We don't know what he says to her. We don't know what he asks her. She never says anything. It's all just kind of, it's kind of like fictional. He's telling this story about this two-dimensional figure who's just dying and is so appreciative that he's there. And I think that what's striking to me, again, is that Dr. Sharon doesn't pick up on any of this. This to her, this is exemplary. And the focus again is on this super sensitive medical student. And we never find out, what did they do for her? What questions, and what is she feeling? She's just there as an object, almost like in a story, if you know what I'm saying.
Okay. So, I mean, right. We're in 2024. This was written in 2006. There's a little bit of white savior stuff going on here. I don't know. Maybe we're being too harsh.
Well, I mean, we could go example after example. I think the point I'm trying to make is that when I look at this work and this body of work on narrative medicine, the many examples, what happens a lot, not in all cases, and in fact, I think I found one example where it really doesn't happen. It's handled very nicely, and I think we should talk about that next. But is this tendency to be sort of focusing on the emotional reaction of the healthcare professional or student without specifically getting into the dynamics of the relationship, what questions they ask, how they get to know that person, what the interaction is like, what they learn, which is all the stuff of being a doctor. Last month, Stefan, you and I did an episode where we role-played a script, and I was the patient and you were the doctor, and it was all about, we were just trying to show how this was just very much of an efficient task completer mindset where there was just a lack of engagement, a lack of connection. And Dr. Sharon might say, oh, well, if this resident had only done narrative medicine and read these stories and talked about them, then they would have interacted differently.
Yes.
They would have been much more compassionate and caring. I think that's what she would say. And I think she and I share the goal that we would like to see that person break out of their efficient task completer mindset. What I'm arguing is that there's much more that needs to be talked about than just getting this student to read and reflect in the narrative medicine framework that we see here. Because what doctoring is all about is learning to engage with other people and to have boundary clarity. This might sound a little crude, but
Oh no.
Yeah, okay. So you've heard me say this. I'll just say it again. My mentor, Simon Oster, once said that it's sort of like masturbation versus sex. And he wasn't putting masturbation down. Masturbation is all about self-exploration. You can learn a lot about yourself, but it's very different from the real thing. That sex is an interaction between two people. It's complex. Now, don't get me wrong. God forbid anyone thinks I'm comparing sex to patient care in the sense that the two are in any way connected. I'm making an analogy between the fact that reading literature and reflecting on literature is a way to learn about yourself and to reflect, but it's different from the experience of patient care, where you have a real flesh and blood person in front of you, and it's all about the nature of that relationship and learning how to navigate that relationship, learning about yourself and how to respond, and how ultimately to form connection, how not to be patronizing, how not to make assumptions about the other person, how to ask questions so that you're ultimately learning stuff that will be empowering you to be helpful to them. That is the distinction that I think is so critical here. And I think and if we don't recognize that there is this big difference between these two activities, then we end up making assumptions that they're more similar than they are. And that's where I think you get into the problems that we're seeing in the examples that we've been discussing here, where there is this idea that, this isn't this wonderful. We saw this patient, we felt deeply about them, and we were deeply moved. The end.
Laura, would you say it's a corrective? That is, I mean, in some of the reading that I did in preparation, I almost heard like, hey, in medical school, we learn to digest people down to generalities about diseases and lists of symptoms, and we lose the person. And would you say, look, that, even the student, we kind of tease the story a little bit, but this is a corrective to the way of formulating patient stories that we're taught in the second year of medical school? Is it could it be redeemed that way?
Well, I do think that's the aim. Sharon talks about that. So does Arthur Frank talks about the sort of universalizing language of medicine. Yeah. It deals in averages, it deals in generalities, whereas people went there particular story is heard, that, there are maybe 100 cases of measles, but everybody experiences them in slightly different ways and has different experiences with them. So the impulse to say, let's look at the particular, let's listen to this person's story instead of, rolling them up into some more universal and abstract idea. Yes, I think it's an attempt to correct exactly that.
I mean, I think the problem is it ends up doing just the opposite, because what happens with, again, these examples is that there's a failure to ask those questions because there are assumptions that are a response to the physician's feelings. So in All Becoming a Healer, I describe a maternal fetal medicine specialist who has autism, and his patients absolutely love him. Because of his being on the spectrum, what he tends to do is he tends to just ask them lots of questions about what they're feeling, what they're experiencing, and then he takes that information, he does everything he can to help them. So they feel very seen. They feel like this is somebody who is highly focused on just trying to figure out what's going on with them and how he can be helpful to them. And I don't think that has anything to do with empathy. In fact, it's in some ways it's sort of the opposite of empathy, right? He's not trying to feel into anything. In fact, he's taking them at face value. And I think that, part of the core of doctoring is problem solving with another person. Like, you walk into the room, you sit down, and the person comes to you, and who knows what's going on. In fact, if you think about last month, Stefan, we have this patient who wants to tell the doctor that he is devastated after finding out that his adult child has a serious neurologic disease. And she doesn't really want to deal with it because she's just trying to get through her to-do list. Okay. And what I'm saying is that if she were just to go, oh, I feel so terrible for you, and then to go on, that wouldn't be helpful either. What we're really looking for is for her to turn around and turn away from her computer and just say, wow, so tell me about that. What's going on? Tell me about your daughter and tell me why you think that might be contributing to your seizures. I need to understand. And then that would be a conversation. To me, that is the act of caring. There may or may not be empathy. There may or may not be feeling into anything. But what there is a genuine concern and a desire to find out what the heck is going on with this person. And I think that's what I feel is repeatedly missing from the Sharon examples. Now, I did find it in one, and actually I think it'd be good to talk about that. It's actually another parallel chart example where I actually think that does happen. And so let's just, where is that one? I think it would be good to talk about that one next. Laura, do you know that one?
Yeah, it's a case where somebody who's been on the wait list for a lung transplant, but they have just found out that they've aged out, that they're too old now, so that they will not get their lung transplant and that they will die. And the medical student writes about this and writes about how awful it is and how awful they feel, but also sort of wonders how the patient might feel, but also just describes being just too afraid to ask. They can't go there. It's too awful.
Yeah, in fact, he writes, I'll just read from here. He says, the medical student writes, I just didn't have the strength to confront the inevitability of my own death, possibly, hopefully, many years ahead of me. As a result, Dr. Sharon says, he couldn't face his patient's acceptance of his fate. And then the student says, it was just too eerie, much too unnatural, and very, very frightening. So the student, in his reflective piece, recognizes that he's paralyzed by his own preoccupation with his mortality in a way that is impeding his ability to relate to this patient's bad news.
There's an outcome, so we have to get to the outcome. So 1 week after the student wrote the essay, read it to his classmates, he visited the patient, who's referred to as Mr. Encarnacion. And during the visit, the student asked the patient and the wife how they had felt when someone else told them that he was no longer a candidate for lung transplantation. Both the patient and his wife wept on hearing the student's question. They spoke at length about their children, their grandchildren. They expressed their trust in God, acceptance of an earthly fate. And from then on, the student was the most trusted member of the medical team for the Encarnaciones, who relied on his advice and guidance in making all future medical decisions. So the students simply asked how they felt, having reflected on this by writing, and probably asked because they wrote, and then earned the trust of this family for all the future decisions. That's an outcome, Saul, isn't it?
It's fantastic. And I think there are a couple of lessons that I would like to at least offer from both the bad and the good. And I really think there are two things that should always be done when you're teaching narrative medicine. And the first is always ask the learner to reflect on and articulate how what they've read or have written could impact their relationship with patients in ways that would be explicitly relevant to the quality of their care. And so I think that's really important. So when you're doing this exercise, if you're facilitating with your learner, whether a medical student or resident, whether it's something they've read that they're reflecting on in the context of a patient or something they've written, you need to get to this key connection, which is, okay, how is this going to change? How might this change the way you interact with this patient in ways that will ultimately lead to better care for this patient? It's not enough to just say, I feel so this, that, or the other. It really has to be, how has this thought process given me insight about what questions I need to go back and ask this patient, and questions that will specifically be therapeutic for the patient and also helpful for me as I try to be helpful to that individual. So that's the first thing that I think needs to always be there. And I think of the 5 parallel chart examples in this book, this is the only one where I see that happen. Okay. The second is do everything you can to create a safe environment where learners can feel comfortable being totally honest about what they're thinking without fear of being judged or that it'll affect their grade. I think they have to feel comfortable disclosing doubts about going into medicine, negative feelings towards their patients, the impact of conflicting values like personal ambition, the desire for wealth, burnout, all things we've talked about on other episodes. Basically, nothing can be off limits. In Dr. Sharon's book, she talks about the fact that when she facilitates this with medical students, she's their preceptor and it's for a grade. And so I think that is going to be a huge impediment. If you know that you're going to be graded, then you have a huge disincentive to be totally honest about some of the things you're thinking that might not be politically correct. And so I think that those are two, and I teach reflective practice with residents at my institution, and it's not for a grade. And I think I do my best to make it very clear that nothing is off the table. And so I do think that those are the two principles, and both of which I see are scarce in the example she gives. The former, as I said, is hard to find. And the second, I didn't see at all. Certainly if you're grading people, you're not going to get that. And so I think those are two things that I think are really critical.
Professor Greene also works with health professional students, right?
People who are interested in going into the healthcare professions tend to take the class, yeah.
What do you strive for with the group of people that includes potential healthcare professionals? What are you hoping to achieve?
Yeah, I mean, because I'm a teacher of literature, right? I try to show them all the things that literature can do to counteract the problems that come up, both when one has illness and when one has to face the way you are treated in a hospital or at the doctor. So trying to combat the way that the healthcare experience for many people might feel commodified, rushed, reducing them to a kind of formulation or generalization or diagnosis. I sort of try to use literature and poetry to try to bring the human back in, to try to help students remember that that's the point.
Laura, you're really good at picking out poems, stories that I think exemplify how we can benefit as healthcare professionals or future healthcare professionals. And I before this episode, as you know, I asked you to pick out one because you teach a lot of them, and you picked out several. I think one of the ones I love is called "Leaving the Hospital" by Anya Silver. And gosh, it's such a beautiful poem. I'd love actually for Laura if you could read it.
Leaving the Hospital by Anya Silver. As the doors glide shut behind me, the world flares back into being. I exist again, recover myself. Sunlight undimmed by dark panes, the heat on my arm, the earth's breath. The wind tongues me to my feet like a doe licking clean her newborn fawn. At my back, days measured by vital signs, my mouth open, an arm extended. The nighttime cries of a man withered child-sized by cancer, and the bells of emptied IVs tolling through the hallways. Before me, life, mysterious, ordinary, holding off pain with its muscular wings. As I step to the curb, an orange moth dives into the basket of roses that lately stood on my sickroom table, and the petals yield to its persistent nudge, opening manifold and golden.
So this is, I love this poem, and it does evoke some feelings for me, but I'd love actually for Laura if you could comment on it first.
I should say that she is dead now. She had inflammatory breast cancer and survived for 14 years. But she has wonderful, wonderful books of poetry about it. This poem I like especially again, imagining about healthcare workers reading it, what it can help them remember. I mean, I imagine that as a doctor or a healthcare worker, walking in and out of the hospital is a sort of pedestrian thing, right? It's nothing, it's just coming in, going out. You do it every day because it's your job. But how different the experience of leaving the hospital can be for somebody who has been in it for a while and being treated for something serious. And so, I mean, first of all, you get, sort of worth paying attention to the images. You get doors gliding shut behind you, and then before you, this other world. So there's this real boundary between what it's like in the hospital and what it's like outside the hospital, which kind of reminds you a little bit, if you've read any Susan Sontag, This is Metaphor, talking about everyone has two passports to the world of the well and the world of the ill, and nobody wants to use the other passport, but sometimes we all have to cross over there. I mean, even the way she uses language then, I exist again, recover myself. Now, normally we think of recovery as what you do in the hospital.
Yeah.
And surely she did some of that because she's getting out there. But the idea that actually at some important part of recovery occurs outside of the hospital, and what you do is recover yourself as though some part of yourself has been lost. And you get a sense of that, I think, later in the poem where she says, at my back, in other words, what I just left, days measured by vital signs, my mouth open and arm extended. I just sort of love that image because that is, things get very mechanized and routinized in the hospital, right? And the nurse comes in and you just stick out your arm and open your mouth because that's what you have to do. And instead, she can now recover herself, her particularity, her humanity in a way that was much harder to hold on to in the hospital. She also describes the man withered, child-sized by cancer. And that is, of course, a painful and powerful description of the kind of loss of flesh that one can experience with cancer. But I think also the sense of being reduced to a child in terms of the power and control that you have.
The sick role.
The sick role, exactly. And the bells of emptied IVs tolling is bells tolling, ask not for whom the bell tolls. I mean, this clearly hints at mortality. So all of that is what is at her back. But then stepping outside, the world flares back into being. I love that verb, flares, like a match being struck. And these images of rebirth. The wind tongues me to my feet like a doe licking clean her newborn fawn. She talks about the sunlight undimmed by dark pain. So there's this sense that when you're in the hospital, you are in this incredibly artificial environment and nature is shut out. You don't have clear access to sunlight. You can't feel the breath. You can't feel wind on your skin. And coming back to that, what a delight that is, what a miracle that is, to step back into that. And ending with this kind of wonderful image of roses, a basket of roses that had lately stood on my sick room table. So she's bringing them out with her there. But there's the sense that they are still closed. They're still buds, as though in the hospital, everything still has to stay tensed up. And then coming out of the hospital, you get this moth, and it's not just a moth, it's an orange moth. It's got vividness and color, and it dives into these roses, and the petals of the rose yield to its persistent nudge, opening manifold and golden. It's just a kind of wonderful image there of life coming back in, insects, even things that are outside, coming back in and opening you up again and revealing beauty again. It's just, to me, a very moving and particular reminder of what it's like to be ill and to come out of the hospital. I mean, when I teach my students poems like this, what I say is, well, you could sum this experience up in a pretty general way. You could say, man, it's miserable to be in the hospital. Everything's kind of artificial. And when you get outside, you feel better again.
Yeah.
Which is what essentially the poem says. You can summarize it that way. But man, you lose everything by that summary, right? I mean, the point of a poem is to give you this particular experience to help you feel it, especially, again, if you're a healthcare worker who goes in and out of the hospital all the time, to say, okay, this is what it's like for somebody who's a patient in here, or at least for this one woman who's a patient here. It's worth remembering that. It's worth trying to hold on to that. Remember that not everybody's experience is like your own.
I think that one point that Laura makes that I think is so important is that a great poem like this sort of transcends analytic interpretation. It's greater than the sum of its parts. And when I read this poem, I am moved. I feel a sense of gratitude just to be alive. I feel a sense of gratitude to be well at this point. And it does that in ways that I don't want to totally dissect. It's quite beautiful. I do think that there are lessons here for me as a physician. I think that it reminds me that I have a special role to play in showing caring to somebody when they are in the hospital. During that dark period, when they're on the wrong side of that door, somebody who shows caring can make a difference. And it reminds me, in chapter 2 of On Becoming a Healer, I describe a story that Rachel Naomi Remen tells of being in her youth and having a serious disease, Crohn's disease. And this was back in the 60s when treatments were not nearly as good as they are now. And she has an ostomy and she's feeling horrible. She's feeling like she's lost her sense of personhood. She feels like she's lost her sense of femininity, which was important to her in those early days. And she decides that she's going to end her life. But then there's an interaction with a nurse who comes in. It's a young woman who's just relates to her as one young woman to another. And it is almost like bringing her outdoors again, bringing her outside of that door. And all of a sudden she starts to feel human again. And she starts to feel hope. And she decides that she's not going to end her life. It just reminds me that although this poem is about the stark difference between the two sides of that door, the life in the hospital, which is bleak and empty and dark and without life, and then the joy of walking outside, then in reality, it doesn't have to be that way. And people can have all kinds of experiences in the hospital. And we as healthcare professionals have a huge impact on whether that happens or not. And if we care about our patients and we relate to them with a sense of shared humanity, and they feel that, they feel known, they feel cared about, then that makes a difference. And I think that to some extent, Dr. Sharon recognizes that in the JAMA story, where she is with this woman and expressing her sense of shared grief over what this woman has learned when she finds out that her grandson has this familial disease. I think that's right on target. I don't want to diminish that, but I do want to say that that alone is inadequate and potentially counterproductive if it doesn't lead to the other stuff that we've been talking about. But I think it's great to end on a poem like this, because I think it does give us a sense that there is so much value in reading thoughtful poetry, short stories, reflecting, but not necessarily feeling like we have to draw grand conclusions from everything we read, or that we have to super analyze it. But that for me, this leaving the hospital, I feel like maybe I'm a tiny bit, it's done something for me. It's done something for me as a person, and probably for something for me as a physician. Stefan, does that resonate for you?
Yeah, I mean, it does for me. And those entries and exits are very powerful, particularly when you're beginning your career and you walk in and out of the door. And I appreciate being reminded, because yes, I walk in and out the door very casually now. Professor Greene, do you want to have the last word on this?
I guess I'll say that keep in mind I'm an English professor, right? But there is just I want to emphasize, or there's part of me that wants to believe that this helps, that poetry helps, that stories help. And sometimes in magical and inexplicable ways, the way Saul was just saying, this poem has done something for me. I can't quite spell it out, but it's real and it's there. That's why I'm in it. That's why I'm doing this, because I think this makes a difference. I hope it makes a difference. And I have learned from my students. I mean, one thing I've learned from teaching this stuff, what it's reminded me of in a sort of painful way, is I sort of assume that all my, the 18 to 22-year-olds that are in my room, that most of them have very limited experience with the medical profession. And boy, am I wrong. I've had, just this last term, I had 2 students, one of whom survived cancer, one of whose brother died of cancer. These are young people who have undergone these enormous, difficult, painful things. And I think that's one reason they like reading this stuff, because it speaks to their experience.
Yeah, absolutely. And I think that because there is so much value in reflecting on great writing for current, future health professionals, for people who have experienced illness in their families or in their lives, and for those who haven't, for all of the above, I think it's so important that we get it right. I think it's so important that we not overstate what it can do, that we don't confuse it with patient care. And I think if we can avoid those pitfalls And then when we do use it in a teaching context, particularly when we're doing it in the clinical setting, that we use it to help future physicians and physicians connect it to the care of patients in a way that is pragmatic and helpful and draws on the way in which they can grow and learn and transform, as we saw in that last parallel chart example, then we're doing something really great. I think if we're mindful of that, then we have the best opportunity to take this incredible resource and use it well.
Yeah.
Professor Laura Greene, thank you so much for being a repeat special guest on this podcast.
Thank you, Laura.
I'm honored.
Saul, thank you for helping steer us to this discussion.
Thanks, Stefan. We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app, as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.